Вітаю. Greetings. Welcome to the continuation of EU-Ukraine webinar series on spinal dysraphism. This webinar series is a joint venture between ERN Eurogen, Omninet Ukraine, and the International Federation for Spina Bifida and Hydrocephalus. This session is also supported by European Society for Paediatric Urology. This webinar is eligible for EACCME accreditation for those who attend the live session and complete the post-session survey. Today's webinar is presented by Rien Nijman and Giovanni Mosiello, and our today's topic is botulinum toxin A in pediatric urology. Sadly, many of our Ukrainian participants are not able to join us online today due to the results of Russian massive attack, which left Ukrainian energy facilities severely damaged and left many regions without electricity. To our Ukrainian participants who are able to connect online, in the event of an air raid in your area, please take shelter immediately. До наших українських учасників у разі звуку повітряної тривоги, будь ласка, спустіться в укриття негайно. A recording of this webinar and answers to questions will be available later. And now it's my pleasure to give floors to our moderator, Professor Giovanni Mosiello. Professor Mosiello, please, the floor is yours.
Yeah. Thank you, Dr. Zymak. Thank you very much for this opportunity to be there closer to you. And as Dr. Zymak told you before, we had a discussion about the terrible situation of today in Ukraine. And we discussed about the meaning to have this webinar while other colleagues of us, Ukrainian colleagues, are under this new attack. And our decision was to do the webinar anyway, because we would like to demonstrate with this webinar the strength of the Ukrainian people. They desire to work together and to work with the European Union. So I hope that you will enjoy the presentation of the webinar with Professor Rien Nijman, and also that the next one webinar in December will be held in a less dramatic situation. And Rien, please, Professor Nijman. Okay. And I don't know if Professor Nijman is connected for the presentation, and anyway, I believe that we can start.
The topic of today will be the use of botulinum toxin in pediatric urology. In the management of spina bifida and other dystrophies, the major indication for medical care is to preserve renal function and to improve quality of life, improving continence. The management must be addressed to the different age of the patient, neurological diagnosis, disease progression, motivation, natural disability, mobility and hand function, caregiver support, previous surgery, comorbidities, and a balance between risk and benefit. In some cases, surgery is required, and surgery strategies must be defined in order to improve bladder storage, working on the detrusor, on outlet, or on both, facilitate emptying, and in some cases, defining a diversion. Before, for improving bladder storage, we had only the augmentation cystoplasty. Augmentation cystoplasty is still used in some cases where there is a failure of conservative management on hostile bladder to preserve renal function for intractable incontinence, but thanks to the devolution of the botulinum toxin, we have completely changed our approach to neurogenic blood. And the today approach of neurogenic bladder, as recommended by the European Association of Urology, see always botulinum toxin after the failure of the first-line management with anticholinergic, but always before bladder augmentation. Botulinum toxin is a neurotoxin protein, is produced by a bacterium Clostridium botulinum, is one of the most poisonous substances in the world. For many years, botulinum toxin has been considered only as a poison substance, but then there was the use in medicine, and in 1989 we had the approval of the use of the botulinum toxin. There are different mechanisms of action of botulinum toxin, and maybe not all of these actions have been well evaluated. What's happening in neurology? In neurology, we have different steps. The first report was in 1988. In 2007, we had more of 1,000 patients treated for neurogenic detrusor overactivity. And the main point to discuss at that time was the safety and efficacy of the botulinum toxin. And different studies have been performed evaluating the different dosage. And the results were very, very good regarding effectiveness and safety, with results improving continence and the quality of life of patients. This report of 2009 by European Consensus of Experts reported the status with the major use of 300 unit and high evidence improving continence, urodynamics, quality of life, and mean efficacy of 8 months. Then we arrived to the approval that was for 200 units, showing the best results in terms that were very close to the major dosage, and so the effectiveness has been established to 200 units. Some authors report a less duration respect to the major dosage. Anyway, at the moment, of course, for the approval, the usage is defined on maximum 200 units in adults. The approval was also for idiopathic detrusor overactivity with 100 unit maximum. In all cases, patient must be able and willing to perform catheterization if required in order to treat the urinary retention that is one of the side effects of botulinum toxin. When botulinum toxin is contraindicated, it's contraindicated in hypersensitivity to botulinum toxin of excipients, in presence of urinary tract infection, in presence of myasthenia gravis, and is not advised in combination with aminoglycosides. The injection could be performed using a flexible or rigid cystoscope and, of course, aseptic technique without infection, where the use of antibiotic prophylaxis to treat urinary tract infection and using longer anesthesia, sedation, or general anesthesia according to the age and the individual situation of the patients. The effects are mainly reported for 89 months and the maximum effect after 2 to 6 weeks. In children, the use has been in the past between 5 and 10 units, with a maximum, of course, of 300 units until the use of 300 units has been permitted for adult patients, and the injection has been performed using flexible and rigid cystoscope. Injection in recommended in the intradetusal area. I would like to report to review in the past very useful because report different experience but with the same results of effectiveness and safety. This review of Dasgupta is of the 2008 on 225 patients, and as you can see, the main duration was 8 months. The dosage was between 5 and 10, and no side effects, improving capacity, reducing the trucial pressure. In this review of Gamay on 2009, we have again different dosage used, and we have very good results regarding continence, regarding reduction of the trucial pressure, and increasing bladder capacity. Then we arrived to the FDA approval for children, and this was obtained thanks to a clinical trial performed in 8 countries and in 21 centers, including our center. And the approval, of course, was at a maximum of 200 units as in adults. The study demonstrated the efficacy and, first of all, demonstrated the safety of botulinum toxin during time. So, during time, we observed in the pediatric population an increasing number of centers using botulinum toxin. On the other hand, we don't see a significant reduction of bladder augmentation. And the bladder augmentation is still recommended in some cases, and when there is a failure of the treatment. And this failure, of course, could be related to a later treatment with the botulinum toxin. Here we can see the bladder, the neurogenic bladder with a trabecule, severe trabecule, and we have to check the bladder in order to define where to inject. The injection is very simple maneuver, and as we have presented before, the preference of the surgeon is related to the choice of a rigid or flexible cystoscope, and also regarding the needle, there is a large variability regarding the use of different instruments. So, botulinum toxin is safe, is effective, but what's happened during time with repeated injection? There is a risk of fibrosis. In adults, we had a different study evaluating this risk. This is the study of Comparat, the study of Aferkamp, the study of Apostolidis, and no one has been reported the increased risk of fibrosis. No significant differences for fibrosis, edema, or inflammatory infiltration. This is our experience. We started very early. At the moment, we have treated more of 240 patients, and the botulinum toxin was evaluated regarding fibrosis risk by us, and this is the only one study published for many years regarding this topic. And we evaluated using the same methodology of the adult colleagues in pediatric population, and we have seen that there is no risk of fibrosis during time in pediatric population. We have defined our specific protocol using this needle and always performing antibiotics, and with using the use of Foley catheter and intravenous fluid in the postoperative period. We haven't seen never severe complication. We have used botulinum toxin in combination with bulking agents for the treatment of vesicoureteral reflux, and we have used botulinum toxin in combination with deflux and button cystostomy as a complete endoscopic minimally-invasive treatment of neurogenic bladder before major surgery. Some concern have been reported regarding the botulinum toxin in neuropathic bladder, if botulinum toxin is useful or not in fibrotic bladder, and the use of botulinum toxin in overactive versus low compliant neurogenic bladder. We have used, as I told you before, botulinum toxin from 1997, and more of 7 patients have been treated with more than 5 injections, and the majority of them are spina bifida patients. And we evaluated on the long term the effect on the botulinum toxin in order to try to understand if there is something different in the bladder wall in patients performing botulinum toxin on the long term or patients that stop the treatment. And we evaluated edema, inflammation, and fibrosis and during the treatment, and we have compared the histological modification during time, histology in congenital versus acquired disease, histology in overactive bladder versus low compliant bladder. At the end, considering all the data, we have considered 36 patients. The mean Botox treatment were 7 procedures, between 5 and 16, and the majority of them were patients with congenital condition. And we have compared the data, and we haven't seen any difference between edema and inflammation, maybe a lower percentage of edema inflammation, the same for fibrosis, and the same between the different group, between congenital or acquired, and comparing the overactivity and low compliant bladder, we have seen maybe, I use the term maybe because of course there are few patients and this is a single center experience, more fibrosis in low compliant bladder and less edema inflammation in low compliant bladder. One term is to define for botulinum toxin is what to do in the long term. And there are many reports from adult center regarding the use on the long-term botulinum toxin and what to do as the ideal number of injection, the site of injection, in order to optimize the results, the best toxin concentration, if antibiotic prophylaxis is always required, if there is a gender effect, if the antimuscarinics can potentiate or not the Botox effects, and also if early treatment prevent neurogenic diffuse overactivity. So if we could consider botulinum toxin not a second line, but a first line. In this paper of the French colleagues, it's interesting to see that more than half of the patients discontinued Botox during time. And the reason, in many cases, is related to the patient decision, and the spina bifida is related to this discontinuation. Of course, one concern is the lack of consensual definition of failure, and the severity of neurogenic diffuse overactivity appear a significant risk for the failure. Of course, some point must be clarified, as the antibody production, the histological status of the bladder wall, and also how to improve the long-term efficacy and patient compliance, as the CIC, and where to perform the injection, if intratrigonal, intratracheal, or subureteral injection. And in this paper, always from French colleagues, these difficulties must be suggested related to the difficulties to catheterization, and also the low tolerance may be due to antibiotic formation. And this is our experience on the long term, where we have seen that in some cases, also in presence of botulinum toxin efficacy, patients required to shift to other treatment. In some cases, they require to come back to another anticholinergics, so to come back to medical treatment. In some cases, they require surgery, they require augmentation in order to avoid to repeat during time anesthesia. In some cases, they require to test for central neuromodulation. Botulinum toxin is effective not only in neurogenic bladder, but is also effective in pediatric population too, for idiopathic overactive bladder. And other use must be to considered for the botulinum toxin as posterior urethral valves. This is a report of 2022 reporting the different use suggested for botulinum toxin. And regarding valve patients, the results are discordant. And of course, one point that must be considered is when this treatment is performed, because of course, maybe best results could be obtained with an early treatment. Botulinum toxin has been used with success also for treating external sphincter dyssynergia in functional voiding, and it's been used with success in patients with pseudo dyssynergia, in patients with cerebral palsy, and is used in the treatment of bladder outlet obstruction, as reported in this paper and in other experience. So, considering pediatric population, dysfunctional voiding, we have to consider also the use of botulinum toxin, because we have an high grade of success improving Qmax, improving continence, and reducing the number of urinary tract infections. One point that, in my opinion, is useful to define, and of course is something that must be defined locally in each country, to define a common protocol between pediatric urologists and urologists that treat adult patients, because as you have seen, this patient require different repeated treatment during time, and useful to use the same approach as we have defined in Italy with this consensus statement what we have defined with adult urologists. So, in conclusion, botulinum toxin is, in my opinion, something very useful that must be considered in all patients that require treatment for neurogenic dysfunction. And going to a specific situation of Ukraine, as you know, we are here for supporting Ukraine in this terrible situation, and European Union would like to support, of course, mainly the patient with frailty as a patient with a rare disease or complex disease. And for this, I would like to remember that there is an opportunity for treatment, for medical treatment for your patients in Europe. And I would like to remember the modality to access to this treatment that is specific for all Europe, and this is specific for my country, for the area where my hospital is located, and I would like to remember that patient could receive treatment in our country and then come back in your country, and this access is open in order to support your patient. Thank you very much for your attention, and see you to the next webinar.
I'd like to say many thanks to our Italian colleagues for supporting Ukraine and Ukrainians. And now, Dr. Nijman, the floor is yours.
Okay, well, welcome everybody. And I would just like to also agree with all the words that Giovanni said at the beginning of his presentation about the very difficult and sad situation in the Ukraine at the moment. Now, what do the guidelines say about botulinum toxin at this moment? First, a couple of words about myself. My name is Rien Nijman. I'm a pediatric urologist living in the Netherlands. And together with Christian Radmayer, we were co-chairs of the initiation of the pediatric guidelines on the management of neurogenic bladder in children and adolescents. I live in the Netherlands. Christian lives in Austria. I live all the way up in the north of the country in Groningen, a beautiful, very old university city. And Christian is from Innsbruck in the western part of Austria. and this is the hospital where I used to work in. At the moment, I'm retired as a pediatric urologist, but still quite active in clinical practice. And I do not have any specific disclosures. So 2.5 years ago, we decided that it was time to have another look at the guidelines as they were printed in the guideline book of the European Association of Urology. And especially neurogenic bladder in children and adolescents presents complex challenges requiring comprehensive management strategies. And the traditional guideline development often lacks input from diverse stakeholders, potentially overlooking crucial aspects of care. And therefore, we contacted a lot of organizations like ERCNet and ITACA and the International Federation for Spinal Dysraphisms, together with IRAN, Eurogen, excuse me, as well as some other organizations to come and sit around the table and to redevelop clinical guidelines on the management of neurogenic bladder in children and adolescents. There's a list of 18 people that were very closely involved, but there were many more people behind the scene also supporting us because it was an awful lot of work. And I'm not going to tell you everything about the guidelines, but there is also a paragraph part on the neurogenic bladder management by botulinum toxin. And this was really a team effort, and that really resulted in a very comprehensive and extensive guidelines. It's not only guidelines, but we also came up with 20 recommendations of the management in children on this particular problem. And we rated and graded all of the recommendations being weak or strong. The novel guideline is still being printed at the moment. It will be available on various online platforms by the end of this month. All the participating organizations, they have their own platforms, and the same guideline will be available on each one of them. We will also go to a couple of international meetings. They're listed here, where the guidelines will be presented, and a summary paper will be published in the spring next year. I also would like to draw your attention to the fact that the EAU has a guideline app that's an interactive tool, including clinical care pathways, also including the management of neurogenic bladder, both in adults and in children. And if you go to the EAU website, you can upload the or download, whatever you want to say, the guideline app. And I think it is for free for everyone who wants it. Now, what do the guidelines say about botulinum toxin? If you look at the text, and I'm not going to duplicate everything that's on the slides, but in neurogenic bladders that are refractory to anticholinergic medication, the off-label use of botulinum toxin is a treatment option. And from the literature, and we studied a lot of different papers, and Giovanni has gone over some of them, continence could be achieved in up to 100% of patients. Also, a decrease in maximum detrusor pressure is feasible in about 1/3 to half of the patients, and an increase of maximum capacity from 27 to 162%. So that is really significant in many of these patients. And also, we saw an improvement in bladder compliance, and you can read the percentages there for yourself. And the use of botulinum toxin A seems to be more effective in bladders with obvious detrusor muscle overactivity whereas non-compliant bladders without contractions are very unlikely to respond. And that is more or less logical given the way of action, the mode of action of botulinum toxin A. Also, injections into the trigone seem to be safe in regard of reflux and upper tract damage. In the beginning, when we started using botulinum toxin, we always taught everybody not to inject into the trigone because it would cause reflux. Well, that doesn't seem to be the case. In patients with a failed augmentation cystoplasty, 34% responded favorably after these injections in a recent series of 30 patients. So even if you have done a bladder augmentation that is not very successful, you can still use botulinum toxin into the remnant bladder. The most used dosage of botulinum toxin A is 8 units per kilogram with a maximum of about 200 units. But you have to realize that also in adult patients, in most patients, 150 units is most of the times enough. Although in neurogenic patients, you need to use a little bit more. In a recent randomized trial, it was demonstrated that 200 international units have greater effect in reducing bladder pressure and increasing capacity compared to 100 international units. Botulinum toxin A can be effective between 3 to 12 months, and repeated injections are effective up to 10 years. That is what we can get from the literature. But probably even after 10 years, you can still be very successful. Giovanni also mentioned the use of botulinum toxin A in the urethral sphincter. It has been shown to be effective in decreasing urethral resistance and improving voiding, but the evidence at this moment is too low to recommend its routine use in decreasing outlet resistance. But it could be considered as an alternative in refractory cases. The next two slides show some of the more important papers on this particular topic, and I suggest, if you're really interested, to have a look at the literature. When you go to the guidelines and you press and you click on one of the references, automatically it will send it, there is a link connected to it, so that you will automatically have access to either the abstract or the full paper. And the recommendation on botulinum toxin, as you can find it in the guidelines, the new guidelines, is the use of suburothelial or intradetrusal injection of botulinum toxin A is an alternative to bladder augmentation in children who are refractory to anticholinergics. Thank you. And I think we now have time for the discussion.
Yes, thank you very much, Rien, for this very complete presentation. And because I believe that to have the clear data of the guidelines, that the methodology that you use is maybe more useful for the audience. I believe really that the botulinum toxin changed our approach to the bladder dysfunction. That is very important in my mind, especially in children. I remember that when I started to work in the Bambino Gesu more than 35 years ago, we don't have a botulinum toxin, and we use in many cases to perform a bladder augmentation, and now the incidence of bladder augmentation or surgery is completely changed, is reduced to very few cases that we haven't the opportunity to start to treat very early. And what is your impression, Rien? Is the same for you?
Oh yeah, we have exactly the same experience as far as the need for bladder augmentation. It is really true that the percentage has gone down enormously. And I think that, well, no, we will have to stick to the neurogenic bladder here tonight. But I agree that the number of kids needing a bladder augmentation is much less than it used to be. Whether that is only because of the use of botulinum toxin, I think it is also very important to again stress the importance of early proactive management in all these children, starting them on intermittent catheterization at a very young age in combination with anticholinergic medication. The problem with anticholinergic medication, especially oxybutynin, is that it does pass the blood-brain barrier and may have some influence on cognitive function in these kids, and therefore parents are a little bit reluctant to use that for a very, very long time. And if other anticholinergic medications or mirabegron do not have the same effect than botulinum toxin, certainly is a good option in these patients.
Yeah,
So it has really changed the whole way of looking at the neurogenic bladder in these children.
Yes, I totally agree. Also because we have the disadvantage, but it could be an advantage for some aspect, that after 8 to 12 months, the effect stops. So we haven't done any change that we do normally with the surgery. I don't know if Dr. Zymak, if you have experience in Ukraine with the botulinum toxin or not.
Unfortunately, we haven't.
Okay.
We don't have.
Okay, and we have two questions, and the first one is from Joseph. Thanks for the perfect presentation. Two questions. What factors determine the ideal injection site and volumes of botulinum toxin in the pediatric bladder to maximize efficacy while minimizing adverse effect? What's your opinion? What is your answer? And I believe that the question was related to intradetrusor, subureteral, or intratrigon injection. What do you think, Rien? We have two different approaches for different patients, or according to your preference?
I think it's according to your own preference.
Yeah.
And especially in very trabeculated bladders, it may sometimes be extremely difficult to find a good spot where you can inject enough of the botulinum toxin. And then, but I normally do inject it suburothelially, which is almost impossible to do in the very trabeculated bladder. So then you have to find another solution. But it is mainly from the level of the trigone up. I usually inject at 10 different sites, going from the right to the left or the other way. And then I always inject some 3 or 4 injections on the trigone. And I've been very happy with that. And if a child is responding favorably to that, usually it's about, depending also on the age and the size of the bladder, whether you can inject in 15 different sites, or sometimes it's more feasible to do it in 10. But I don't think that that is really that important. But maybe you have a different approach there, Giovanni.
No, I totally agree with you. I believe that it's important to have something well standardized in order that every time there is the same procedure, and also in order to understand the real effect during time. And we had the question was about the dosage. I believe that it could be if we have different effects with 200 or 300, because I have seen during time that before the approval for adults at 200, that of course lead to have the approval for pediatric patients to 200 units at the maximum. When we use the 300, we had a strong effect, maybe for longer time. This was the same experience of you, Rien?
Well, in adults without a neurogenic bladder, but with severe overactive bladder, usually we use 150 units max. And there have been a couple of different trials that show that there is not a lot of difference between the use of 150 or 200 or even higher dosages. There is some, but it is not a significant effect. So I think that in younger children, it's about 100 units, and then maybe in the older ones, you can go up to 200 if you want to. But it doesn't seem to be that significantly different how much there either is a good response or there isn't. And then I don't think the dosage, but I mean, it's better to stay on the safe side here. We have to deal with very young kids developing, so you don't want to overdose them.
One question more is for how long? 1, 5, 10 years of lifetime until we have effect. What is your answer, your opinion?
Well, I mean, if you look at the literature, the really long-term results, I mean, on average, that's about a 10-year period that is covered now. And if it is still successful, you might as well continue. I don't think there's any reason to stop it.
Yeah, I totally agree.
So you can continue. And there is also no good evidence in the literature that the longer you use it, that the time it is effective is getting shortened. Most of the time is the same, somewhere between 6, 9, or 12 months.
Yes, it's the same impression. I've seen that a very few cases, no responder, or a very reduced responses, but a responder during time. And one question is related to the general anesthesia. And do you consider that a problem with repeat anesthesia? My opinion, no. And because we use a very, as a sedation, because we perform in many cases also a local anesthesia. And what is your opinion?
Well, I mean, we've had a lot of discussions about anesthesia in general in younger patients. I think that the evidence that it does have an adverse effect is rather weak, to say the least. So I'm not afraid for general anesthesia when it's given in a proper way. Yeah. But like you say, I mean, the first time we inject it, we always do it under general anesthesia. And then you can you make a selection, because there is a group of patients without sensibility in that area. Or you can do it under local anesthesia, injecting lidocaine in the bladder or whatever substance. And that is very well tolerated.
Yeah, I totally agree. And one point in my experience to stress, and the neurogenic bladder related to spinal cord injury is different from the neurogenic bladder to spina bifida. And also in adolescents or in young adults, I have seen injecting a spina bifida patient that on the dome there is a sensitivity. And so the idea that, okay, there is a spinal cord lesion, and because spina bifida is considered as a spinal cord injury, that is not true, because there is a difference on sensitivity, because it's often not complete lesion, and we have injecting, there is a pain for the patient. Is the same in your experience, Rien?
Absolutely. I agree completely with that.
Yeah. Okay, I say that there is experience in Lviv and from Dr. Shevchuk, and we are happy about that. and if there is some comments of him, I would like to report. And we have other question about the other colleagues about the complement, what the means of early treatment, early symptoms of overactivity, early urodynamic finding of high pressure, low capacity, early finding of no response to anticholinergics. What do you think, Rick?
Well, that's a lot of questions.
Yeah.
I think that early proactive treatment starts in the first couple of weeks after birth. And then we don't have urodynamic data. And our policy is that we start almost all children on antimuscarinic drugs, oxybutynin in combination with intermittent catheterization. We do a urodynamic study at the age of 3 months on average, so that's also quite early. And then some of the children can stop, and sometimes it is not very clear, so they just continue. But as soon as they have normal voiding at normal pressures, then you can discuss whether intermittent catheterization and or anticholinergic drugs can be stopped. But normal voiding in this group of patients is extremely rare. So I think we are on the safe side in the majority of these patients. Early treatment is not only good for the kidneys, but it is also good for the bladders, because if you do not treat them properly, there will be fibrosis of the detrusor. And once you have a fibrotic detrusor muscle, it is extremely difficult to reverse that or have some medication that have an influence on that. And those are also the bladders that usually don't respond to botulinum toxin anymore, because they are stiff bladders, and then you are too late to do anything. Then the only option probably is a bladder augmentation. So I'm still very much in favor of early proactive treatment. And if you have patients that come to your office every 3 months when they are young, then maybe a more conservative approach is feasible. But especially if there is always a risk of losing patients to follow-up, that is very dangerous.
I totally agree with you. And regarding the early treatment, and one note regarding the age, and the first treatment in pediatric population has been done on a sphincter injection and a myelomeningocele. If I remember, it was about 18 months old boy, and this could be something, of course, off-label, but useful use, and to inject the outlet when patients are not able to start or don't accept the clean intermittent catheterization, because you can induce with the Botox a chemical denervation of the sphincter, and there is the limit that the injection, in my experience, in the outlet is the duration is limited about 3-6 months and no more. I don't know if it's the same of your experience, Rien?
Yeah, exactly the same.
Yeah. Okay, one question is what about the intravesical local anesthesia? And as I told you before, and in my experience, I use it in very few cases that are adolescents that I can consider young adults, and normally I use 1 ampoule of lidocaine in 50 millimeters of saline solution, and I left the solution inside for 15 minutes, and then I start the procedure. Which is your experience with the local anesthesia and Rien?
Well, that's exactly what we do. The nurses inject the lidocaine into the bladder, and well, we wait a little bit longer, maybe 20 to 30 minutes to be on the safe side, and then it works perfect.
Okay. Last question that we received is from Marie. If you have an hostile bladder not responding to anticholinergic but non-incontinence, how and when do you look for the effect of Botox wearing off? To not missing high pressure treating the kidneys? Hostile bladder not responding without incontinence, and we have to decrease the pressure, and this is the meaning of to use Botox is to avoid an high end-filling pressure inside the bladder. What do you think about that? We use the same because continence is one of the concern that the patient could present, but not only continence. Rien?
Well, I think that if you have a neurogenic bladder, I don't think that whether the child is dry or not is always that important.
Mm-hmm.
Because there's a lot of variability whether a child is dry in between intermittent cath or not. So I think if you do it primarily because there is a high pressure in the bladder during storage, and the child is dry, that is even more dangerous because then there is a very strong external sphincter mechanism that doesn't relax. And those were always the children in the past that after some time went into renal failure because they are blowing up their kidneys. It's the same in the spinal cord injury patients that have this phenomenon. So I think that in those patients where you use botulinum toxin to lower the intravesical pressure, the detrusor pressure, you have to measure it.
Yeah.
And then whether they are dry or not is a secondary outcome measure. So I would not go on that as an endpoint, being dry or not. It's the pressure you have to monitor.
Yes, I believe that maybe the question of Mary was related to the fact if what we can observe as a clinical science and without performing urodynamics. Of course, at the end of the effect of the Botox, you can observe the incontinence, and because is what the patient refer in many cases, but in other cases we don't have incontinence if we have a severe dyssynergia, but what we observed was the appearance of a urinary tract infection and the dilatation in the upper urinary tract with at the ultrasound. So if you would like to avoid to repeat the urodynamics, and I can understand the question of Mary, because if we perform urodynamics, it's a time-consuming, it's invasive procedure, and we have to move the patient to our center if the patient is not resident in our area. But anyway, we can observe with the ultrasound what's happening to the upper urinary tract. Do you agree?
Well, basically, I do agree. But the other thing is that you can teach parents to do urodynamics at home.
Mm-hmm.
Because they have to put in a catheter a couple of times a day anyway. If you give them an IV drip, a tube connected to the catheter, and they lift it, and they can read how many centimeters of water pressure is in the bladder at that particular moment. And then they can empty the bladder and see what the volume is that is related to that particular pressure. So doing home urodynamics for some of these patients is a very good solution and very cheap, doesn't cost anything.
I totally agree, and this could also be useful in some situation like the situation that now there are patients in Ukraine are living. The last question that we have received is always by Marie, and about the effect of the Botox 3 months, 4 months, 5 months, 6 months, and so we have to perform a cystometry every 3 months. I don't believe so. I believe that it could be very important to study the patient after the first treatment in order to understand the duration of the effect And then for the other one, for the other injection, I believe that other signs, clinical signs, or also simple manometry at home, as you suggested, Reed, could be useful. What do you think about that?
I think that in general, we measure the result after 2 or 3 months once. And then when the child starts leaking again, or when the volume that the parents get out of the bladder gets down, those are signs that the effect of botulinum toxin is diminishing. And then that's probably the time you have to repeat the injection. So it's the clinical signs that probably are the most important ones at that stage.
Yeah, I believe that we have a last question, and then we have to close. Is a question by Dirk that is a very good question, and this could apply to high pressure bladder following posterior retral valves, etc. I agree. What do you think, Rien?
Well, the only thing with the valve patient is that they have a completely normal sensation.
Yeah.
And that means that repeat injections with botulinum toxin in those patients sometimes is a big issue. Because you can only do that under local anesthesia a couple of times, especially when they're 8, 9, or 10 years old.
Yeah.
And otherwise you have to repeat it every 6 or 9 months under general anesthesia. And some parents don't like that at all.
Okay. We are out of time because we are 7 minutes more. And thanks for all. And Dr. Zymak, please, if you would like to be so kind to close the session. Thanks, Rien, for your participation. And
you're welcome.
Yeah.
Many thanks for our understanding speakers, and thank you for your very interesting presentation and sharing your views and experience, and for wonderful discussions. Dear colleagues, thank you for the actively participation and the lively discussions too. See you later. Thank.
And stay safe.
Okay. Thank you to all. Thank you to be there, especially to the Ukrainian colleagues that will be able to participate today also in the so difficult situation. And we will coming back in December with the 12th with a webinar on the derivation, and we hope to see you again. Thank Rien, and thank Natalya, and a special thank to Darren and Parmida that follow us for this webinar. Thank you very much. Thanks to all.
Thank you very much. See you.